Welcome to the Sports Talks podcast, everyone. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
And on each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice.
On today's episode, we're focusing on anterior shoulder instability with Dr. Brian Lau, orthopedic sports medicine surgeon, team physician for Duke Athletics, and director of the FIFA Medical Center at Duke. We have some really great articles that are going to contribute well to our conversation on the treatment of primary anterior shoulder instability. As always, links to all these papers can be found on our podcast website, www.thesportstalkspod.com.
So we're going to start off our discussion today with a Level 1 RCT published in the March 2020 issue of JBJS titled Primary Arthroscopic Stabilization for a First-Time Anterior Dislocation of the Shoulder. This single-center, double-blinded clinical trial compared arthroscopic washout to arthroscopic Bankart for the management of primary shoulder instability. At an average follow-up of 14 years, the rate of recurrent dislocation was significantly higher in the washout group compared to the Bankart repair group at 47% compared to 12%. The arthroscopic Bankart repair group also demonstrated significantly better clinical outcome scores, including the WOSI and DASH scores.
Then, from the June issue of JBJS this year, we review the publication entitled Remplissage Reduces Recurrent Instability in High-Risk Patients with On-Track Hill-Sachs Lesions. Albert Lin and Pat Denard performed a multi-center retrospective study of patients with on-track Hill-Sachs lesions who underwent arthroscopic Bankart repair with or without the addition of the remplissage procedure. We'll discuss on-track versus off-track Hill-Sachs lesions, how you go about calculating this, and what to do with this information, and with a little bit with our guests. So for now, let's just focus on the results of the study, which showed that the addition of remplissage was associated with a lower rate of recurrent dislocation, so 1.8% versus 11%, and revision surgery, 0% versus 6%. Remplissage protected against recurrent instability, particularly in those high-risk patients.
We're joined today by Dr. Brian Lau, a board-certified orthopedic surgeon, dual fellowship trained in both sports medicine surgery and foot and ankle surgery. Dr. Lau obtained his medical degree from the University of Pittsburgh and completed his orthopedic residency at UC San Francisco. He then went on to complete 2 fellowships, the first in sports medicine and shoulder surgery at Duke University, and a second in foot and ankle surgery at Stanford University. Following training, Dr. Lau returned to Duke University, where he is the team physician for Duke Athletics and the director of the FIFA Medical Center at Duke. Dr. Lau is the Associate Program Director of the Duke Orthopedic Sports Medicine and Shoulder Fellowship and serves on numerous educational committees in AOSSM, ANA, and ASES. He is passionate about research and leads the Duke Sports Medicine Research Committee. Welcome to the show, Dr. Lau.
Okay.
So welcome to the show, Brian. Thanks so much for being here with us today.
Well, thanks for having me, Ashley and Catherine. Excited to be a part of this.
Awesome.
Yeah, us too.
So you've published extensively on shoulder instability, and you're also currently involved in a clinical trial ongoing right now on 3 different types of surgeries for shoulder instability: open Bankart, arthroscopic Bankart with remplissage, and lateral J as well. So we're really excited to hear your take on this topic today and how you decide what surgical treatment is best for your individual patient population. But before we dive into that, we want to talk a little bit about the decision to proceed with surgery versus Nonop. So if you have a patient, first-time dislocation episode, and I'm purposely leaving this vague for you, what kind of factors are you looking for, patient factors and imaging factors, to help you decide on proceeding immediately with surgery or attempting some non-op treatment?
Sure. Yeah, obviously a very interesting topic, and a lot of literature has been published on that, particularly first-time dislocators. Mm-hmm. So if assuming it's a first-time dislocator, the things I'm looking at are going to be kind of age, like how old they are, what sports, also what level of sport. If it's going to be recreational sport versus a collegiate versus professional athlete, that changes what I'm thinking. How many times they've had it done before? Is it their dominant side or non-dominant side? What their goals are, what they want to get back to, and also where we are in the season. Those are things that I'm definitely making sure I get on the history from. And then the exam is going to be, initially it's going to be trying to get back their motion back. But how unstable they are, some of your physical exam findings. But those are the kind of key things that I'm looking for early on in the history and when I'm hearing about that story.
Yeah. And, I think it's always a discussion. You're hitting like all those sort of major points where for, that young person sort of happening at the end of the season, they're already going to miss playoffs or, whatever it is, it becomes a little bit of an easier discussion. But then, those sort of in-season athletes, it really is, there's a lot of, it's a big discussion. And I don't know, Ashley, if I've actually ever told you this, I dislocated my shoulder.
You never told me that.
Last summer.
What?
Was it last summer?
Yeah, last summer. So
Wow.
I'm in the older category. But
How is your rotator cuff, Catherine? Okay, I'm just kidding.
So I went to one of the local physical therapists because mostly I was just having so much spasm after. I won't even tell you guys how I did it because it was really something I used to be able to do that I can't do any longer. So I won't embarrass myself. But I was like, oh, my deltoid is just so sore. And he's like, that's not your deltoid, right? And I'm like, I know. Like,
I
I'm just in denial.
Oh,
But anyway,
man.
I'm sorry to sidebar
No,
there.
but you didn't need surgery.
Well, I'm just in denial, but
okay.
Yeah.
Got it. Awesome. So Brian, in that thread, Catherine comes to your office.
Yeah.
How are you managing that? Are you attempting some Nonop treatment? And
I guess I asked her what her goals were. So if you want to get back to lacrosse in season, then we would try some non-operative stuff first.
Yeah.
Try to rehab it back. Well, you can get back in the season. If it comes again after the end during the season, then you're out. So that's generally all tip. If you got one chance, then if it comes out a second time that same season, you're probably gonna be out. So
yeah.
I think really, really good point. Ashley, do you do anything any differently, or do you have anything else to add there?
No, I think that you guys really hit the nail on the head. Definitely age, imaging factors, looking for obviously significant bone loss, significantly large engaging Hill sacks. We'll get into that discussion in a little bit. And then definitely the timing of the season. And that kind of brings me to the next question I want to ask is like, how do you determine when they're safe to go back in? So you have an athlete, they're just starting their season. They're like, absolutely not. College scouts are coming. I'm going to play D1 lacrosse. I can't be out this season. How do you determine when they're safe to go back in? I don't really know that we know that answer, but Brian, are there certain things you look for? Is there like a time criteria they have to be out?
I don't really have a time criteria. It's more of how well their range of motion is, how well their strength is. Can they protect themselves? Can they do everything at the level they want to be at? Okay, so if you get back for those scout tell periods, if you go back out there and the scouts are watching and you're not playing your best, that could hurt you more than it helps you. So you want to make sure you're able to do everything you can in practice at the full level before you get back to play. So it's not really a time thing. And then another thing we're trying to do is a little bit of functional testing as well, where it's not just how they're feeling, but we actually do some functional testing with that too to see how they do. But
right.
what do you do for some of the lacrosse players?
Well, I was going to say, there's this, I'm just going to bookmark the functional testing because I would love to hear what you guys do. But
yeah, me too.
The lacrosse wise, there is sort of this very highly downloaded video of this guy, Connor Busick, who's now the head coach, brought his team to the Final Four. That was last season. So he's the head coach of Cornell now, but he was also a player in the PLL. In the first season, there's sort of this clip that gets sent around a lot in the lacrosse community where, he was a chronic dislocator. He basically dislocates mid-game. You see him coming off. He's obviously his shoulders out. He goes to the sideline, and no joke, game clock, about less than a minute later, he's back in. And in the professional league, that they have a 2-point sort of arc. So he basically gets a 2-point goal a minute later. And you're just like, how is that? He's totally out, arm dangling on the sideline, gets popped back in, and then he goes in the next play and scores. So I think sometimes, that's a chronic dislocator, right? It's not he knows exactly what he needs to do. He knows when he's ready. But I would say, if it's their first dislocation, certainly that's never happening where they're going back. You're sort of just kind of resetting the situation, seeing how they're doing. And, Brian, like you said, really just evaluating, what's their range of motion? Are they able, what's their apprehension even? Psychologically, do they even want to go back in that season? So I think sort of those early sort of signs of how they're feeling.
I think you make some really good points about chronic dislocators for first-time dislocators. those patients who are like, oh, I can pop it back in, like they tend to often be able to get back in the game at the same time almost. The first time dislocators, they're not going back to the same game probably.
Well, I'll pose a question to both of you about that scenario. So I'm just thinking in terms of, that's great, they can pop it back in and get back in, but if they can pop it back in that easily, what does that say about the health of their shoulder? Catherine, I guess I'll ask you first, how do you counsel that athlete? I mean, definitely something they obviously wouldn't want to do in season, but definitely off season. I mean, are you telling them about like the destruction and damage they're doing to their shoulder? And like, how does that conversation go?
For sure. And I think, it really varies. So if you're looking at the lacrosse community, maybe their ability to stay as a professional player is only going to last so long. So there's, they might be having that sort of conversation with themselves that they're saying, okay, maybe I only really get to do this for 2 or 3 years. And if I have a surgery and, I'm out, I'm not sure I'm going to be able to get back in the league. Meaning like, I'm not sure I'm going to be able to get to that same level of performance. There's only so many teams, there's really just like one professional level. Like, will I be able to get back in? And if so, I think they're adults, right? At that point where they can decide, okay, I know all the risks, I know all the variables. So I think it's really just having that discussion and just being, especially in the lacrosse community, a lot of these guys are really well educated. They're smart. You can have a great conversation with them about like the risks and benefits. And, at the end of the day, we're just there to provide the information. And, I think they sort of make that educated choice.
Yeah, I agree. That's a really good point. I always have a hard time when you have a high school athlete and you have that discussion and they say, well, in the NFL, he just went right back in, a couple of weeks later. And I go, you don't have like a multi-million-dollar contract. Like I care about your shoulder. And like, of course it's situation dependent, but I think that's a really good point, Catherine, about the limited seasons that they have and the risks that they're willing to take at a specific level of play versus when you're dealing with maybe an adolescent who has their whole life ahead of them. Maybe it's a different kind of conversation.
Absolutely.
Awesome.
So, because we bookmarked that functional testing. So can you talk a little bit, Brian, about some of the things that you look at with your athletes?
Yeah. So, on the field, we don't have anything, but, if after they've gone off the field and say it's a week or 2 or 3 weeks later from the injury, we've developed a battery of tests at Duke where we have a combination of patient surveys as well as functional testing. So the surveys include the WOSI scores, a shoulder instability return to sport index scale. And then we check their strength. We check endurance testing. So we do, they'll be basically doing a push-up position, trying to move their hands, at least that way. We have so that's an endurance testing. We also do posterior stabilization. So they have this where they're kind of lifting their arm up in a certain position and holding it for as long as they can, some weight. And then we do performance testing on this. It's like a performance plate, and we put them in different positions. And that allows us, we put what's called the ASH test. We put them in different positions, in the I position, Y, and T position. And that allows us to check both their overall maximum strength, but also the rate of strength. So, maybe you'll get maximum, but it takes you like 3 seconds to get there when it should take you like half a second. Then are you really protecting yourself in that sudden motion? We need to really rapidly fire those muscles to help stabilize the shoulder. And so that's a series of tests that we look at, and we don't have baselines on them. So that's something we're working on, but it does give us a sense because it stresses the shoulder. So sometimes they'll get in that, T position or like, this doesn't feel right. And that, in that sense gives them that feedback, like, okay, I'm not ready yet. So.
Yeah, I think Ashley and I have talked about this on this show before where, doing a large battery of tests, whether it's like for return to play testing or what have you, oftentimes it lets the athlete see, oh gosh, I thought I was ready, but I'm really not. So I think the more sort of data or the more sort of tests you put them through, it actually helps them sort of like their buy-in. So you're not just sort of being this like, amorphous bad guy of like, oh, you're just not letting me play. You're like, right. When they actually see, oh gosh, I can't do this yet. I have to like work on this next little component. It, gets a lot better buy-in with the rehab.
Yeah. And that's, I totally agree with that. It's easy because we say, oh, somewhere between 4 to 6, 8 weeks, a month you can get back after surgery. But now we said there's some hard data that we're going to look at, and you can see your improvement, and that reassures people that you're not just like pulling them out, like you said. And I think that's, kind of jumping here, but that's kind of highlighted in one of the articles that you guys sent out from Pittsburgh, we've based some of the same studies from them in terms of the tests that they do, but they show just having a return to play battery decrease that rate of re-injury by like fourfold or something like that. So
yeah, I think we know that. We quote the ACL literature all the time that if you just deciding based on time is not enough, right? We need actual objective data. And I think that you make a really good point about trying to find baseline values. Are you using a general baseline value for an age and position matched and sport matched athlete? Because you really can't use contralateral side due to dominance, right? So it can be really challenging. But as Catherine alluded to, we do talk a lot that having that data can be helpful for patients to know what to focus on as well too, and to know what they need to work on in order to ultimately obtain clearance, whether that's for non-operative or surgical. So yeah, we'll talk about that paper in a little bit after we have a discussion about surgery, which we probably should do now. So enough about that non-op stuff. So we decided we're going to do surgery. And you've gotten some imaging. I mean, I think we're all getting MRIs, right? But you're going to do some calculations to determine, if a patient can be treated with, an arthroscopic Bankart. Do they need a remplissage? Do they need a bone reconstruction procedure? So I guess I'll start off with, what imaging do you get? What kind of X-rays? Are you always getting a CT? What kind of motivates you to get a CT? If not, what are your thoughts?
Sure. So if a patient comes in de novo to me, so I haven't been referred and they come to me, we're getting MRIs on them. And we developed over the last several years a 3D MRI. So that allows us to make measurements. And we've, a recent paper by Lander et al. That we validated that it's equal to the CT scan. So it's actually really nice because we're able to get comparisons for 3D imaging, everything we get in a CT scan done for MRI. And so it doesn't matter if you're first time or multiple dislocated patient, you have all that data, which is, we're looking back at that, which I think is important. A lot of the data and papers that are out there looking at bone loss are really looking at MRI 2D imaging scales. Yeah. Whereas this one, our hope is that we'll be able to look back and see that even your first time, how much are we actually getting measurements? How much are we actually losing? And so we're fortunate to have that. So we get that imaging, off the bat, and we make all the, the measurements. And interesting what kind of measurements you guys make. Obviously we have a series that we're looking at, but what are you guys looking at? Are you guys getting MRIs or CT scans or?
Yeah, I'm doing an MRI and I'm just seeing if I can get that cut. I think if it's bone loss that I think is well under that 10 to 12% cutoff where I'm really worried, I wouldn't get a CT. If it's larger, like a true bony Bankart, that's really almost like a glenoid fracture that I need to visualize to determine how I'm going to fix it, or a chronic dislocator where they've got that inverted pair and I really have to calculate to see if I can do a lateral J or if I need to do more of a larger bone block procedure, then I'll get the CT scan. But I'm really excited to hear, I think we reviewed that paper where you validated the MRI versus CT, at least in the lateral J paper we're going to talk about in a little bit. And that's exciting. Yeah, because it's no radiation and it's one imaging study for people versus having to send them back to get this imaging done. So it's my long-winded way of saying I don't routinely get CT scans unless it's a unique case. And I just try to calculate the bone loss based on that sagittal image that has the best fit circle.
Yeah. I mean, same. I think, especially in that younger population, if we can save them, we have to have a good indication to get the radiation, right?
Yep.
But quick question about the MRI. That's what you're describing, the 3D. Is that still study-based or is that out with your general population at this point?
That's out with my general population now. So that we published that maybe 2 years ago, that validation study. The paper that you guys pulled was one of our secondary studies in the same cohort. And then there's a third one that's being published. Looking at decision making between 3D MRI and 3D CT. Like, does a plan change based on whatever image you have? And we found that it doesn't. So the plans are the same. So that's going to come out in JCS in the next couple of months.
I know that none of us are sort of like imaging experts or, as far as from the radiologist perspective, but is that something that you guys foresee can be applicable nationwide, or is this something that you really need a specialized center?
So very good questions. That comes up a lot. And so the sequence we have is called the VIBE sequence, which is based on a GE scanner. But there are comparable sequences that are compatible with all the different ones, all the different companies. So VIBE is what's called for GE, but it can be called X for something else. And I have a list of those if people are interested in, but that it can be transferred over from company to company based on that sequence. So it's something that could definitely be transferable, and you may want to, it would probably be something you want to validate a little bit just to verify that, but it's transferable across, even from 1.5 to 3T, whichever one you have. So.
Oh, wow. 1.5 too. So I don't know about you guys. I insist on a 3T MRI just because I always like to see the detail. But the fact that it can translate across to a 1.5, I mean, that's pretty much every MRI facility. That's fantastic.
So that would be the next iteration that we're trying to do with the ATX bone loss group, is to try to validate across institutions and companies. So.
Okay. Yeah, very cool.
Awesome. So I do have a question, and I ask everyone when we talk about shoulder instability. So are you calculating this glenoid track? Are you plugging these numbers into that 0.83? Is it only in certain cases where you're on the line, or is it just when you're teaching your fellows and your residents? What are your thoughts?
Yeah, definitely adds it when your resident fellows are there. You're going to try to make sure you bring it up. But
exactly.
So I'm doing a general So in all honesty, I look at the 3D images, and if it looks like you have a general gestalt, like this, I should probably slow down and measure more. But there are some you look at and like, there's no bone loss. It's not really need to measure. But if I'm all worried, then I'm going to slow down and make sure I make those measurements on those scans. So.
What about you, Catherine? Are you pulling out that calculator and doing the measurements?
Yeah, I would say similar. Like, if you sort of have an obvious sort of case that you need to dive into the details, you do, but certainly not every case you need to do that. But very happy that we had, Ramapa and people in Price and residency and Preventure who had us do all those things. So every case.
Exactly. Exactly.
So yeah, I think obviously all these measurements and calculations, they do guide our overall decision making, but other factors, like we kind of started to talk about, like when we're looking at indications, they're also, guiding us, like, sport, position, age. But, let's just start with like the soft tissue based procedures. So, Brian, for you, like when you're doing an isolated arthroscopic Bankart repair, in terms of like what patient characteristics, image findings, because you do hear of some people like right away going to, like a lateral, and sort of being like, this person is young, they're going to keep, and that is on, one aggressive side of the spectrum, but certainly there's a big role for the soft tissue. So, for you, what's your ideal candidate that works into that category?
I mean, I think that's a great question. There are definitely people who would jump to lateral J for any contact or collision sport. And like, it doesn't really matter how many times, it doesn't matter what the label looks like. I'm just going to do a bone block procedure. For me, I'm a little more selective of that. I mean, I feel confident with my soft tissue repair. And so, but yeah, if they have bone loss less than 13, 15%, I'm probably going to go to a soft tissue. And, soft tissue could also be adding remplissage, depending on what that glenoid tract looks like, what the heel sac looks like. But generally we'll, try soft tissue based procedures for lower bone loss, smaller heel sacs, on track, even if it's slightly off track, depending on what their goals are, contact sport, and stuff like that.
Yeah, absolutely. Yeah, I completely agree. I think that I think there's so many complications associated with lateral J, even in the best hands. And I just feel like if you can save that as a secondary procedure if needed and not rush to it for the first stage, if it's a patient that doesn't have a lot of glenoid bone loss and an on-track heel sac lesion, I completely agree with you. I don't think that there's really a need to rush to that, but I know that really is surgeon specific.
Yeah. How are you guys deciding on remplissage? Is it the glenoid tract? I mean, there's talk about near tract, distance to dislocation, or is it sport specific? Or how do you guys decide to add that extra thing to your labral repairs?
Go ahead, Ash.
You want to? So I would say I'm using it more and more. So I feel like if you had asked me that 5 years ago, I would say, if it's, minimal glenoid bone loss, but an engaging heel sac lesion, you got to fill that defect. And that's when I would use it. I think there's a paper I believe we're going to get to soon, or we can get to it now. Pat Denard and Albert Lin looked at adding a remplissage to cases of low glenoid bone loss and non-engaging heel sac lesions, and found that it lowered the rate of recurrent instability in high-risk individuals. So what are those? Male contact athletes, some glenoid bone loss, but less than 15%. I think it's I don't want to say easy, but it's a pretty easy arthroscopic procedure to add. If you place them pretty centrally in the lesion, which you can, if it's a small defect, you're not really limiting rotation. And I think it's just that added backup I think it really tightens up the shoulder and it minimizes that risk of recurrent instability. So I have a really low threshold to add a remplissage. If they're a contact athlete and I'm doing a Bankart, I'll add that remplissage if there's even a small Hill-Sachs lesion, just to give that extra support. But maybe that's aggressive. Catherine, what do you think?
Yeah, I would say, kind of similarly, I found more utility for it. And I think Denard is obviously a really good scientist. And, I have a lot of respect for his work. And I think it did show a reduction in the revision rate. And I think I'm always sort of trying to figure out, in this population in Colorado, there are a lot of people who want to climb. And even if it's just a little bit of a hobby for them, and I have not seen the reduction in rotation yet, but that's something that I'm thinking of in the back of my mind. Like, am I going to make them too tight? So that's something that, like, I would say gives me a little pause, but I haven't actually seen that as like a complication yet. Does that make sense?
That's so funny you bring.
I have a patient who, same exact thing, rock climber, and was feeling great, but not quite when we did the remplissage, and I was all worried that she might lose that rotation, and she was worried about it. We had talked about it, and she's so far been doing pretty good. I mean, but those are the populations with overhead kind of contact, and actually gymnasts. I know Ashley, you do a lot of gymnasts. Those are the ones that I worry about because they need that motion, they need that flexibility, but then they're also ones who get a lot of shoulder problems.
Right.
What do you do with a gymnast?
Yeah, so I was just asked this recently. So I feel like a lot of times with my gymnasts, they have an underlying element of hypermobility. So a lot of times I am doing, a capsular shift while I'm doing this. But because they have that hypermobility, I feel like when they dislocate, they don't have as much damage. Like, if anything, they have a pretty small labrum tear. They don't have as much of a Hill-Sachs because they shift out and shift back in. And so I'm not doing remplissages in them as much. And maybe a benefit of that is that I'm not seeing as much loss of external rotation. Though I was just talking to other surgeons about this, and they also felt like it's reported in the literature, loss of external rotation, but anecdotally, other people aren't seeing loss of external rotation. I think if you have a large lesion, maybe historically they were only being done with large lesions, but I think like medium-sized lesions, especially if you put it like more centrally, I haven't really seen that. So I don't worry about that as much, but I think I'm not doing it as much in that population because they don't tend to have as pronounced Hill-Sachs because of their hypermobility.
Yeah, I think that's a good point that maybe they were, that early data, they were done in larger lesions, and maybe that's where the rotational deficits came from. But yeah, it's something that worries me because you feel like you just take them out of, they need that position and they're just going to be so unhappy if they can't get there.
And your lacrosse players too, right? I mean, the attackers shoot both sides. So it's, if they lose that external rotation, they're not going to be happy. And you'll get that with the ladder, Jay, but you won't get that with an isolated Bankart, right? So it's a balance, I think. It's a conversation with them.
Yeah, for sure. And then we kind of glossed over, but when we were talking about just the soft tissue-based procedures for the labral repair, we know that there's been papers that JBJS paper that's been out like almost like 2 decades for the number of suture and anchors was related to failed arthroscopic stabilization. And that number that was always drilled into us in residency was 3. Like, you have to have at least 3. So
and those were when there were giant anchors too. You're just like, where am I going to put this third one? It's a tiny glenoid.
Any thoughts on that? What do you tell your residents now about that? I would be curious. Like, is that something that has stayed within the academic sort of world, or is there a change?
So 3 is still a number, but I'll say for a standard Bankart, I'm typically doing 4. I'm typically doing 1 in the 7 o'clock position, really trying to bring up that, inferior capsule and getting that. So I'm actually doing a 7 and then like a 5:30, 4 and 3, so I tend to do 4 if it's a standard Bankart. Now we see a lot of, for contact collegiate athletes, we see actually ones that go over like 180 or 270, but for your standard Bankart, those are the ones I'm doing typically 4 anchors. Now I think that's I still do a simple stitch with those anchors. I do a knotless technique. So I use a single simple suture. Now, I think the number for 3 or 4, whatever it is not super accurate. There's a lot of anchors now that have like double loaded anchors, whatever. So it's really the number of fixation points, I think, would be more accurate than saying the number of anchors. So if you're using an anchor that has, 4 sutures in there and you're tying across, it's really more like, that's already 2 fixation points. So I think that's more important than saying the number of anchors. if you're doing simple sutures, then it's a no bankers. But if you're doing something more else, and I know I haven't experimented with the horizontal mattress sutures with it, and I don't know if that plays in. But I don't know, what do you guys? Are you guys doing horizontal mattresses or mostly doing simple sutures?
Mainly with me, it's been simple. I haven't been fooling around with the new, sort of horizontal. Ashley, have you?
No, I haven't. I do the industry name drop here. I did the Arthrex 1/8 knotless anchors. I just really like them, and I'm able to pull up when I do the reduction. But Holovax in our residency did all horizontal, but into a push lock. So it's I think that, and he got a really nice bumper. So I definitely think I haven't had to, but if I put that first fiber tack in, pulled and did it, and I didn't get that solid bumper, I could see myself passing a horizontal, with a push lock and going to that. Because I do think it gives you more of a better bumper, but a lot of times I think you get a good enough bumper using the other implants.
Catherine, are you using the same Arthrex knotless fiber tack too?
I am. I will say that sometimes I would use the push lock. So but when we were in training, so in Vail, that was something like the newer Arthrex knotless, that was something that we had a ton of, because they were sort of piloting a lot of it. So we had that in our lab. So I think I got very comfortable with it, just practicing with it a lot. So I think that's probably my favorite.
Yeah, I'll do the push lock. So if there's a little bit of bone loss and a displaced labral tear, and I feel like I'm gonna have to pull it a long ways, I'll use a labral tape or suture tape, really more than labral tape, and push lock, and put that in. If it's more of a standard, minimally displaced or just folded down, I'll use a knotless fiber tack, which is generally what I'm using. But I do use push lock, but I feel like I'm gonna have to move it quite a bit.
Yeah. I do keep both in the room, just because you just don't know, what you're going to need sometimes. But I've been happy with them both, honestly.
What I like the most about the knotless, I mean, it's easy. That's always a plus, but that because it's so small, I can do more anchors. I always felt with the push locks, they're 12.5, they're 3.9 push locks. It's been a while since I used them. I mean, versus the 1.8, I mean, that's almost double the size or double the size. And so I feel like I can do a lot more. Like you mentioned, 4, I can easily get 5 or more in a labrum repair there. And I don't have to worry about as much the points of fixation. But yeah, you guys make a really great point that if you need to get that tissue really pulled up and really robustly made into a bumper, I think it's a really good implant to use.
Yeah, for sure. I assume, those ones where, you're going all the way around, you're going lateral, but are you doing any of these in beach chair? Because if stuff is really just anterior, I stay beach chair. But are you guys doing everything lateral?
I do all my instability lateral, unless I'm in there for another reason, like a cuff or something I'm doing. Or if I'm doing a ladder J and I'm scoping ahead of time, then I'm going to do beach chair. But standard-wise, I'm going to do lateral every time.
Yeah. Same. I just, it's funny. I almost switched entirely to doing lateral after doing the Jersey Shore rotation at my fellowship where they do everything lateral. But then I switched back to beach chair. But for instability, I just feel like I get such a good visualization, can make my way around the glenoid clock face.
Yeah, no, it is really, really nice. Millet does everything beach chair, and he just does it all perfect no matter where you are.
I think it's also what you're used to too. I was just talking, we where we trained, correct me if I'm wrong, Catherine, we were almost exclusively trained beach chair. And I remember learning that and being good in the beach chair. But then just once I saw lateral, it made, I don't want to say more sense to me, but it was just easier in my hands. So I think if you're trained beach chair, you've got it. If you try to do a lateral, it might be more challenging. So I think it's your reps.
Yeah. For sure. I think the one thing I like about the lateral is that you put that camera anterior superior and you can do anterior, posterior. I mean, there's some data out there to show that if you do lateral, you tend to put more anchors because you can do it easily without having to move your camera too much. Whereas beach chair, you have to move your camera posterior, anterior, maybe make a separated portal. So it's just an ease to kind of work around. I joke with people that maybe the reason I see more 180, 270 tears is because I'm doing lateral, so I can see everything really easily. And so I'm like, let's put another anchor. It doesn't take that much.
It's like the subscap tears, right? You may not have seen it, but it's seen you. It's like maybe we all have 270-degree labrum tears. We haven't seen them. So, Brian, I have a question for you. I feel we all talked about arthroscopic. Sounds like we're doing a lot of arthroscopic. Are you doing open Bankart repair? And if so, what are your indications to proceeding with an open Bankart repair? Is that common for you, or is it more rare?
It's a great question. That's what the OASIS study is trying to help us identify. So that's that, 10 to 20% bone loss. That's one of the arms of the study. And I would say with the study, though, we're actually having a hard time getting patients to enroll with that because there's going to be a lateral J or a arthroscopic repair for remplissage. And even amongst the surgeons, we have a dozen or so surgeons who are in that group. Only several of us were very comfortable with open Bankart. I've trained a lot in it. I was fortunate I got a lot of that training when I was in fellowship, and so I feel comfortable doing that. But even with that, I tend to do that more for patients in revision settings. Say they have had a labrum that I feel like was done well, 3 or 4 fixation points, and no real heel sac, but I still feel uncomfortable, then I'm going to do an open to kind of restore that Bankart and also add in that capsular shift. And so I'm not tending to do that in primary patients, but that is part of the arm of the study that we're trying to understand where that role for the open Bankart is going to be. But yeah, probably don't do that nearly as much as I do for the other bone block procedures or arthroscopic. What about you guys?
I think it's really just, you're lucky that you got a lot of it in training. I think for people in training nowadays, it's like it might not even come up. Like you're saying that some of the surgeons in your study group are not even like saying, hey, I don't even want to be one of the surgeons that does that. I think that's going to become more and more and more.
Yeah.
Yeah, it's so funny. I was just doing a webinar on shoulder instability, and that question got asked her. I was like, how many open Bankarts have you done in this? And I was just like, I held up like 0. And I was just like, Bill Levine's going to like find me and just like, because like they give all these talks about you need to know open Bankart. I did not see one in my fellowship. Like I went to a great fellowship and like in residency, Catherine, I don't know if you did, I didn't. And so, yes, I do open Hagels. So like I could do an open Bankart, right? But it just, I don't, and I think that is definitely something, Brian, you're academic, you work with residents and fellows. That's something I think the next generation needs to learn. I think we're so good at arthroscopic now. We don't really teach the open approach. And I think it has utility, like you were saying, revision, capsular laxity, things like that. I think it really has utility.
I would say that's something you mentioned with the gymnast and the laxity. The ones I've done it for tend to be gymnasts.
Yeah.
Because it's, less, there's not much bony defects as you mentioned, and more of like a overall laxity that comes with it, sort of kind of an MDI picture, but not maybe fully MDI. So
absolutely. Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the first part of our discussion as much as we did. On the next episode, we'll continue our conversation with Dr. Brian Lau and shift our focus to the management of glenohumeral instability in the setting of more significant bone loss, and then finish up with a discussion on return to play. Make sure to subscribe on iTunes, Spotify, or wherever you get your podcasts to stay up to date on all things sports medicine. You can also check us out on YouTube. If you like what you hear, please consider leaving us a review and subscribing. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod and Twitter at thesportsdocpod. We love your feedback.